Welcome everybody to this webinar on multi-criteria decision analysis. My name is Martin IJzerman. I'm a professor in the Department of Health Technology and Services Research at Twente in the Netherlands. And we've put together this webinar series. There's a series of 3 webinars on MCDA, actually to introduce you to the field of multi-criteria decision analysis. So if you guys have any questions or feedback, you always can drop us an email. So this is on the first slide. It's one of my colleagues, Henk Broekhuizen, University of Twente. Or you can drop an email at info@panaxea.eu for any questions you may have. And of course, we'll be happy to take any questions if you use your chat box. So there's a chat box that you can use. So if you have any questions during this webinar, please let us know. Okay, I'll kick off very briefly with the introduction. So we have a series of webinars on the use of multi-criteria decision methods in healthcare, and that you may have an experience in healthcare. This is kind of a complex field of research which involves multiple and also conflicting criteria that you have to consider simultaneously in making decisions. And at that point in time, we started with using MCDA, multi-criteria decision making or analysis, as a way to structure a decision problem and to explicitly consider the different criteria in making a decision. So we've done quite some work on MCDA. And today we've seen a steady growth in use of MCDA approaches in healthcare. So we've seen different applications in health technology assessment, actually to guide reimbursement decisions and to consider the different factors involved in making these decisions. We've seen some studies on benefit risk assessment. There's been some work in the European Medicines Agency on the use of multi-criteria decision-making methods to support benefit risk assessment. We've done quite some work on stakeholder engagement, particularly patient engagement in shared decision making. And finally, MCDA is also being used in some sort of practical strategic business decisions, like, for instance, building a new hospital. So there's different applications of MCDA. The objectives of this webinar actually is to start from the basics. So we would like to create awareness in the use of MCDA and to introduce the basics, and also we'll give you some guidelines to implement MCDA in your own work. So the topics that we will cover, there's actually 3 of them in 3 different sessions. So we will start today with an introduction to the basics of MCDA, which is by one of my colleagues, Janine van Til. Then we have another webinar in a couple of weeks on group decision making. So you can actually implement MCDA to support group decisions. So the next webinar will be on that. And the final topic will be on some methodological issues regarding the application of MCDA in healthcare. This also has to do with dealing with uncertainty in MCDA models. Of course, there's a whole bunch of literature that you can use talking about MCDA or dealing with MCDA. And if you have any requests, we can provide you with some overview materials, some overview papers, and also a practical tutorial on the use of MCDA to start your first experiments. So if you have any questions on literature, please let us know. We'll send you a few articles. So just to sum up again, today we start with the introduction to MCDA today. The next session will be on the 22nd of April, the use of MCDA, the group decision support approach. And finally, the methodological issues are covered on the 29th of April. So there's at least four people that will be providing these webinars, except from me just as an introduction today. I'd like to introduce you to Janine van Til. She's going to take the first webinar today. Janine is an assistant professor in the Department and has done quite some work on stakeholder engagement, in particular patient elicitation, patient preference elicitation methods in MCDA. Henk Broekhuizen, he's the organizer of these webinar series. He's a PhD student in the department, actually working on sensitivity analysis and uncertainty in MCDA models. Then Karen Groothuis, she's a biostatistician in our department, and she will be working on methodological issues. And finally, Marjan Hamel, also is an assistant professor in the department, and has quite a lot of experience with applying MCDA, in particular the analytic hierarchy process in group decision support. So this is the course faculty for the 3 webinars. So I would like to hand over to Janine to follow up on this with the first introduction into MCDA. And once again, if you have any questions, you can drop your questions in the chat box, and we will reply to that immediately. Janine, I'll switch over to you. Here you go.
Okay, thank you, Martin. Just a casual remark with regard to the questions. I now can see them. I see a new thing popping on my screen. I do not promise to answer to them immediately, but I will answer them in due time during the presentation. So what is this session about? This first introduction session, I will first go into the basics of what is multi-criteria decision analysis. I will introduce you to the process of MCDA and discuss some basic information about the steps involved. I will focus on the model building part, because other stages of the process of MCDA will be addressed in the other sessions. And finally, if I have time, I will show you some examples of the use of MCDA in healthcare. Like Martin said, decision making is based on trade-offs, often trade-offs between multiple outcomes. And to make it even more complicated, these outcomes can be competing. The trade-off is circumstantial, depending on the specifics of the decision context, the decision problem, and the decision maker, the person that is responsible for making the decision. And those trade-offs are inherent to that decision making. They are based on the decision maker's values. Just to highlight this by giving you a direct example, if my slides will cooperate. I'm sorry, there's a minor mix-up with my slides. I can't seem to go to the next slide. If you take, I will just go ahead while my colleague will hopefully repair my computer. If you take the example of shopping for jeans, which I think that everybody does once in a while. And here's the slide. The criteria which could be involved, which are involved when I'm buying the jeans, are, for instance, the price of the jeans, the color of the jeans, the fit of the jeans, the brand of the jeans might have some influence on which jeans I prefer. And these criteria can be conflicting. Fit of the jeans is often improved, which is something I would like to maximize. It's often better in jeans that are more expensive. The jeans that are the color of the season are often more expensive. So these different criteria can be conflicting and therefore competing in my decision to buy certain jeans. The actual decision and the relationship to the decision context is the type of jeans I prefer, the type of jeans I would like to buy, depends on my existing wardrobe, resource constraints I might have, a specific purpose that I have to wear the genes, and the importance of the decision maker and his or her values becomes obvious when we compare the genes that you and I buy, and my genes are often very different from the genes that other people buy. So this is a very simple example of what a multi-criteria decision problem could be. Would we make a model for this decision? Probably not, although I have done that in the past, because the decision has limited consequences. The effects of me buying the wrong genes are short-term. When I get my next salary slip, I can buy another pair of genes, and therefore the consequences of a wrong decision are easily remedied. In contrast, healthcare decision-making is complex. Determining diagnostic and treatment plans for the individual patient in the clinical context, or service provision, decisions of the hospital and the hospital management on what services to provide, how to provide access to patients, and which treatment plans and priorities with regard to the development of the hospitals are available and are preferred. Organizational policy context decision making, reimbursement decisions, market access decisions, these are all very complex decisions which depend on different criteria, which depend on multiple criteria, and which depend on the specific values that are considered in the decision. Multi-criteria decision analysis seems a fitting decision support tool when we consider the need for more informed, more systematic, and higher quality decision making. Now, what can MCDA do? There are some mistakes about what MCDA will actually do. One of the major ones is that MCDA will give you the right answer. No, it will not, because for once, there is no right answer to most decision problems. There are just answers that are close to the decision maker's values. And MCDA is not an optimization framework where the best right answer comes out of the decision. Then will MCDA provide you with an objective answer and take all subjectivity out of the decision? No, it will not, because subjectivity is inherent to decision making, and subjectivity remains, for instance, in the choice of the decision criteria that you're going to consider, but also in the structuring of the decision problem, and, for instance, in the weights that you assign to the different criteria. However, this subjectivity, which is inherent to these decisions, will be made explicit. So MCDA will help you to make subjective decisions more explicit. And objectivity is increased, for instance, by the use of measurement scales. Now, will MCDA take the pain out of decision making? No, it will not, because decision making will still involve difficult judgments of value. And sometimes it will, the use of MCDA will even make decision making more complex. However, what can MCDA do? MCDA can guide you in the decision-making process. You learn more about the problem situation, about your own and other people's values, and about the judgments that are inherent to making that specific decision. MCDA will highlight the trade-offs and the subjectivity of the decision, and by doing so, it will increase the transparency of the decision that is made, both to you, yourself, but also to the outside world, to external parties that might benefit or be harmed by the decision you have made. Like Martin said in the short introduction, there are multiple examples of multi-criteria decision problems in healthcare. On the individual level, decisions have to be made by individual patients, for individual patients, or by physicians about appropriate diagnosis, treatment, and for instance, end-of-life decision treatment plans. On the organizational level, budgets are constrained and have to be allocated over different parts of, for instance, a hospital, but also the way in which service is delivered and estates are managed can be supported with multi-criteria decision analysis. On the national level, we have some experience with budget allocation decisions, health priority setting, and benefit risk assessment. And also in the field of medical product development. For the healthcare sector, MCDA is used at present. When you look at the use of MCDA in healthcare, you see an increase in the number of publications in healthcare over the years, where the increase in clinical papers has started relatively earlier, and in recent years there's an increased use in health systems and methodological papers related to MCDA and the use of MCDA in healthcare. This highlights the increased interest in MCDA in the healthcare context. Now the important question, what is multi-criteria decision analysis? In multi-criteria decision analysis, there is the consideration of different alternatives. For instance, very simply, alternative A, B, and C, or in the example of the genes, different types of genes. Then you have to specify different criteria which influence the value of the alternatives to the decision maker. And last, you use a structured way of comparing the alternatives on all criteria to come up with a preferred alternative based on your own values and the criteria that play a role. When you look at the process of MCDA, it consists of different phases. Most importantly, I think, are the first two phases of MCDA, problem identification and problem structuring. If you make mistakes during these phases, this influences all other phases of the MCDA and finally the interpretation of the results and whether or not these results can be used in practice. Model building is the central stage of MCDA, where the problem and its structuring are transferred to an MCDA model, which can be then used to inform thinking, challenge your own thinking about the problem, and finally developing a plan for the implementation of your MCDA analysis. As becomes clear from this process is that model building is only one stage of MCDA analysis, and therefore the most important and the result of this stage is used in the fourth stage to inform your thinking, and therefore the preferred alternative or the alternative for which a plan is developed to implement isn't necessarily the alternative which is preferred during the model building stage. However, in this session we're going to almost omit the problem identification and problem structuring phase, which will be central to the second session. We will focus on model building, and model building can be subdivided in 6 different stages, which we'll discuss subsequently. But first we must identify what different multi-criteria problems there are in healthcare. First, we have the choice problem, where a decision has to be made to do either one thing or the other. A choice problem can be a yes-no decision, and therefore can also be a decision which concerns only one alternative. When you look at the sorting and ranking problems, you might think about priority setting in policy healthcare, in healthcare policy making, where the government has to decide where to spend the money, and usually this is not a decision for one area, but rather a prioritization of different areas where the focus will be on for the next 4 years. And finally, a description problem, which is usually a problem where the alternatives and the criteria are not well defined yet, and the MCDA is used to come to this better description of the problem. Linked to these different problems, there are different models which can be used to model these types of decision. In a value measurement model, numerical scores are constructed to represent the degree to which alternative is preferred to another. So the outcome of a value measurement model is always one numerical score for one alternative, and these can be compared to each other. Most value measurement models use a compositional approach, where scores are calculated for all criteria separately, and the overall value of all alternatives is calculated based on some type of synthesis model. A utility theory model is a value-based measurement theory model. However, this is under conditions of uncertainty, so the explicit probability of reaching some type of outcome is taken into account. In goal aspiration or reference level models, which can also be associated with numerical scales, specific satisfactory levels of performance are defined prior to doing the analysis, and for each alternative it is determined whether or not this alternative meets that satisfying or aspiration level on all of the criteria independently. And finally, in outranking models, alternative courses of action are compared pairwise, and the only relationship that is established is whether one alternative performs better with respect to that specific criterion than other alternatives. In healthcare, value measurement models are the most used applications of MCDA. However, in theory, satisficing and outranking models could also be applicable to the same problems. However, because it's most widely used, we will focus on value measurement models for the rest of the lecture. Now, when we look at healthcare problems, we discussed that there are multiple models which you can use. And the second, once you have determined the model you're going to use, you need to determine what the alternatives are that you're going to consider. Now, in clinical decision making, this is usually a comparison of different courses of action. For instance, a patient in end-stage lung cancer can decide to focus on quality of life and by choosing less radical treatment. He or she can also decide on quantity of life and therefore choose the more higher impact treatments that will prolong his or her life as long as possible. So in this case, there are usually multiple options which are well described, well defined based on clinical literature. However, individual patient criteria can play a role, and these must also be defined in the analysis. When you look at hospitals and the type of decisions they make, and therefore the alternative actions that they can take. They have many more options. Usually these kind of decisions have multiple, but sometimes even unlimited options, and the goal of the analysis is to come to a smaller, more well-defined set of alternatives. Reimbursements and access decision-making usually focus on one alternative, and the decision for that specific alternative is whether or not to adopt that treatment or to allow that treatment on the market and to reimburse it on a national level. Now take the example, a very practical example of choosing a hospital. Choosing a hospital which is your preferred hospital in your own case to go to when you experience a health problem. When you face that decision, you first have to select the alternatives. Of course, in this case, in our region, we have 3 hospitals that are relatively close and could be our preferred hospital of choice. But what criteria are we going to use to determine what is the best option for us? Well, first, criteria, it must be stressed that criteria can be both qualitative and quantitative. So there's no need to include only quantitative criteria in your analysis. It seems like an open door, but criteria also must be relevant. That is, they must be linked to your objective of your analysis. For instance, the color of the hospital on the outside might be something that differs between the alternatives that you're considering, but not one that is relevant for you in choosing a preferred hospital. Then your criteria need to be measurable. That is, you must be able to measure your alternative on an ordinal scale based on preference. You must be able to state whether the performance of your alternatives on these criteria has a certain order and one is preferred to another. And it must be possible to link numerical scales or a numerical outcome to each of the performance of your alternatives. Then your criteria must be non-redundant. This means that there must not be more criteria that describe the same underlying factor, because you will then double count for this effect. For instance, if you both include the criteria travel time and miles or kilometers to the hospital, so distance, both distance and travel time, it's a fair assumption that a large portion of these two, the outcomes of these criteria are redundant, depending, of course, on the area where you live. And finally, criteria must be preference independent. That is, you must be able to state your preference for one criteria without knowing anything about the performance of the alternatives on the other criteria. It cannot be that you are willing to travel more or longer, more miles or a longer time for a hospital that is white than for a hospital that is black. Of course, you can end up with these 4 criteria with an unlimited, very large set of criteria that to you seem relevant to picking your preferred hospital. However, it's also important to balance completeness with concisiveness. You must keep your model operational, and you must be able to use it with reasonable effort. Increasing the number of criteria you include in your analysis will make your model difficult to operate and difficult to interpret. Fourth, it's important to determine the shape of your value tree. When you look at the decision here, which is determined by 3 criteria, this is a one-level hierarchy tree. All criteria are on the same level, and all your alternatives must be valued on all these 3 criteria. In contrast, this is a 2-level hierarchy where the decision is influenced by criteria 1 and criteria 2, but criteria 2 in turn is influenced by subcriteria 2.1 and subcriteria 2.2. In this case, your alternatives only need to be valued against criteria 1 and subcriteria 2.1, subcriteria sub 2.2. So in other words, your alternatives only need to be valued on the lowest level of your criteria. And this can go on, and you can make very complicated decision trees. The shape of the value tree is first and foremost dependent on the underlying characteristics of the criteria. So these criteria must be related in some way to criteria 1. And the same is true for the criteria that you put on the criteria 2 and the criteria that are under criteria 1. So the higher level criteria describe some comparative characteristics of the underlying subcriteria. A more pragmatic approach is also related to the efforts needed to weigh all these criteria, and dividing your value tree in more levels can reduce the number of value judgments you have to make, or that the respondents to your analysis has to make. When we take our example of choosing a hospital, for me, the value of the hospital is determined by its size, by the distance I need to travel, by its reputation, and by the facilities it offers. So these criteria to me are relevant to determining the value of the hospital. When I put these criteria in a consequence table, I can describe the size of my alternative hospitals A, B, and C. I can describe the distance I need to travel to these 3 hospitals. I hopefully can get a description of the reputation of this hospital, and I can make a list of the facilities these 3 hospitals offer. Then it's important to determine what your goal is or your objective is related to the different criteria. For me, I prefer smaller hospitals, so hospital size is something I would like to minimize. Distance, my travel distance to the hospital is also something I would like to minimize. I would like to travel short as possible to reach the healthcare facility when I need it. The reputation of the hospital is something I would like to maximize, and the facilities of the hospital are also something I would like to maximize. So once it's clear what your criteria are and what your objective is with regard to the performance of these of your alternatives with regard to these criteria, you have reached the evaluation stage of your analysis. And the first step that you need to do when you want to determine a performance scale for your different criteria outcomes, which are the outcomes which should be described here, is to translate that raw performance, for instance, the distance you travel to the hospital, to a 0 to 1 scale. In this graph you can see that for me, 0 kilometers travel, that would be living on the doorstep of the hospital, has a maximum value of 1. In contrast, traveling 10 kilometers to the hospital is the longest distance I have to travel to reach one of the 3 hospitals in my target area, and that this has a value of 0. This is a case of local scoring. In this case I have used the minimum distance and the maximum distance available within my alternatives to determine my performance scale. Now this is a linear function, and it's a negative marginal value function because the value decreases with the increasing level of the performance. But you can imagine there are all kinds of different curves or different shapes to this value function. For instance, it can also be a positive marginal value function where value increases with increasing performance. Here we have an example of the reputation of the hospital, which can be poor, can be average, or it can be good, just a simple 3-point scale. And the value of a hospital that has a poor reputation to me is 0. The value of a hospital with a good reputation is 1, and a hospital which has an average reputation, because of the linearity of this function, has a value of 0.5. Now this shape doesn't need to be linear, it can also be curved, and it can have an exponential curve, and it can even have a parabole shape. So there are all kinds of different shapes to your value curve. Linear functions are mostly preferred because they are easier to interpret and make your analysis more simple. Here you see the formulas to come to these different utility or values for the different performance levels. In case of maximizing performance, you can calculate the value of that alternative on that criteria by taking the actual raw score, subtracting the minimum score, and dividing that by the difference between the maximum and the minimum score available in your dataset. For minimizing criteria, you take this function, you calculate the value score by taking the minimum score in your set, subtracting the actual raw performance, and dividing it by, again, the difference between the minimum and maximum, and you then add 1 to this number. If we again take my example of choosing a hospital, these are the different characteristics of my hospital. They differ based on the number of beds. They are different based on the distance that I need to travel to them. Their reputation, the reputation of alternative A is good, while the other two have an average reputation. And for simplicity reasons, I have made the outcome of the facilities a simple yes or no score. Yes, the hospital has all facilities that I need, or no, the hospital does not have all facilities that I need. What are the exact facilities that I need? I would leave out of this discussion. To just highlight the difference between local scoring and global scoring, here are two examples. In local performance scoring, you take the actual raw performance scores in your data set, which are in this case 10 kilometers, which is my least desirable distance, and 2 kilometers, which is my most desirable distance. You give the least desirable distance a performance value of 0, and the most desirable performance a value of 1. If there are intermediate scores, you use the formulas on the sheet prior to this to calculate that intermediate score. This will perform perfectly well if your only goal is to do this one analysis. However, if there would suddenly become, if you would suddenly include another hospital in analysis, and that hospital is, for instance, 20 kilometers away from where you live, you could not use the data you have already collected to calculate, to take that alternative into consideration. If you want to do that, you have to use global performance scoring. In global performance scoring, you have your actual worst and your actual best. You have your most desirable, which is again living on the doorstep of the hospital, and your least desirable, but still the distance you would be willing to travel to your hospital, which is, for instance, 25 kilometers. Of course, you can still travel to hospitals that are further away, but for me, this is the maximum distance I would be willing to travel for a hospital. This least desirable performance level gets a value of 0, and the most desirable one gets a value of 1, and the actual performance scores again calculated based on the previous formulas in the previous slide. Now this is the first step of the valuation process. So first you need to calculate these the values that are aligned with your performance of your alternatives on the different criteria. Now the next step is to determine the weight of the criteria itself. Now often people translate criteria weight as in, this is how important this criteria is to me. However, this is not a true definition of what a criteria weight is. A criteria weight is a scaling constant that corrects for the difference in performance, in the width of the performance of the previous step. So it corrects for differences in scale properties between the different criteria. Now it's important to highlight that criteria weights always sum up to 1. That is, in your analysis, criteria weights always need to sum up to 1. There are different ways to come up with these criteria weights, and these different methods to elicit criteria weights do not necessarily adhere to this criteria, but in that case, initial scores are again normalized until this criteria is met. One way of asking for how important these criteria are is to ask to first determine the most important criteria. For instance, for me, the distance to the hospital is an important criterion. Then you can ask what the second most important criterion is. And this could be, for instance, the size of the hospital. If I now award this most important criteria with 100 points, the next question would be, how relative to this most important criteria with a score of 100 points, what score I would give to the size of the hospital. And that could for instance, be 60 relative to the 100 of the most important criteria. The second session will study weight elicitation, or will describe weight elicitation in more detail. Now, if we go back to the choosing a hospital example, we have seen that the value of our hospital is determined by the 4 criteria: size, distance, reputation, and the facilities available. Previously, we had the actual raw performance scores in terms of the number of beds, the distance in kilometers, the reputation described by a qualitative score, and the facilities available described by either a yes or a no. In this slide, I've translated those scores into value scores. 1 for the maximum performance, I've used local scoring, and 0 for the least desirable outcome. And in some cases, there are some intermediate scores, for instance, with regard to reputation. In this column, I've added the weights of the different criteria. In this case, I have decided that distance is the most important criteria, and size, reputation, and facilities are all equally important to me. Therefore, distance has a weight of 0.4, and size, reputation, and facilities have a weight of 0.2, which adds up to 1. Now, the way to calculate the value of these different alternatives, A, B, and C, to me, based on my preferences, I would use this value function. And this value function describes the value of alternative A, which is the sum of the different weights multiplied by the value of that criteria, the value of that alternative on that criterion I. So this is an additive value function. You calculate this additive value function for alternative A, alternative B, and alternative C in the case of my hospital example. But of course, you can do it for a much larger set of alternatives. When I do this for choosing my hospital example, I come up with an expected value of hospital A of 0.8, an expected value of hospital C of 0.4, and an expected value of 0.3 for hospital B. Which means that in terms of rank order, I prefer hospital A to hospital C, I prefer hospital C to hospital B, and I prefer hospital A to hospital B. And hospital A would be the hospital of my choice. Now, of course, just like me, you're still curious about the genes. I did the same for the genes, and I came up with the expected value of 0.96 for the bootcut diesel genes, a value of 0.65 for the G-star, again bootcut genes, and a value of 0.59 for the SlimFit Peppa genes in blue, which means that I can go to the shop and buy this type of genes. Now, this was only one example of a value measurement methods used in healthcare, of a value measurement methods which could be used in healthcare. In healthcare, actually, the analytical hierarchy process is the most used method. This value tree is a mistake in this slide. I will correct that for the slides that come to you afterwards. And session 2 will be all about this analytical hierarchy process. Now to demonstrate some examples of the use of MCDA in healthcare, you here see an example by James Dolan, where they developed a patient decision aid for colorectal cancer screening based on the MCDA method. This is an individual level decision support analysis. And the value tree for this analysis is as follows. This is the objective of the analysis. Of course, choose the best approach to colorectal cancer screening. Again, not the best option, but the best option to that specific patient. Or not the best option per se, but the best option, best approach to the patient. And the aims are to avoid colorectal cancer, to avoid major side effects of screening, to avoid false positives in screening, and a category of other considerations which are subdivided in the frequency of testing, the preparation needed for testing, and the procedure involved in the screening test. Now there are 6 alternatives which are compared. The wait and see, so that is no screening, annual stool tests, flexible scope every 5 years, a combination of both, a barium enema every 5 years, and a colonoscopy every 10 years. Weights are determined for the 4 criteria and for these 3 criteria among themselves, and each of these alternatives is evaluated on all the lowest level criteria, which are avoid colorectal cancer, avoid major side effects, avoid false positives, frequency, test preparation, and test procedure. Another example of MCDA method on the organization national level is a comparative evaluation of different immunization policies. This is really a prioritization issue. And as you can see here, the decision tree consists of, the value tree consists of 3 different levels. There are 2 alternatives which are compared, and the objective is again stated here. I will just skip the last example. Well, this was, like I said, only one way to determine the best or the most preferred alternatives from a set of alternatives in using a multi-criteria decision model, using value measurement theory. Alternatives theories are these utility theory, satisficing and goal programming, and outranking. And different methods are associated with all these different theories. I now described in the previous slides, I described an example of SMART. Session 2 will focus on AHP and Macbeth. And session 3 will be a more general description, or will include a more general descriptions of the pros and cons of different methods. Just some finalizing statements. While we see an increased interest in the role of MCDA in decision making in healthcare, there's considerable variation in its approaches, partly explained by the different variety of methods which are used. And it's important that both further theoretical research and practical application is performed to explore the specific pros, but also the cons of the use of MCDA in healthcare decision making. And just a reminder with regard to the next sessions, I do not see any questions at this point, but I'm asked to remind you that the next sessions are on the 16th and the 23rd of April, and this information is stated wrongly on, which is probably this last slide. So this should be the 16th and the 23rd of April. I thank you all for my interest. Of course, I'm available for questions afterwards through email or phone or even personal questions or even questions in person. Thank you very much for your interest again, and see you in the next session.